Hi everyone, and welcome to Health Equity Teachers video on Introduction to LGBTQ plus Health. My name is Colleen Wong. Let's get started. Here are our learning objectives for the video. Define the following sexual orientation and gender identity terms: sex, cisgender, gender identity, queer gender, sexual orientation, sexual identity, transgender, and transsexual. Explain important components of a thorough sexual history and considerations when obtaining one. Describe unique clinical concerns and disparities of adult LGBTQ+ patients. Describe preventative care for sexual minority and transgender individuals. And list resources and health clinics available in your state to address the variety of health needs of LGBTQ+ patients. So let's start out by defining some sexual orientation and gender identity terms, also called SOGI terms. Many of us have heard of LGBTQ+, but to whom does this acronym refer to? L stands for lesbian, G for gay, B for bisexual, and these are sexual orientation terms. T is for transgender, Q for queer or questioning, and there may be a lot of letters after Q as well, and that's indicated by the plus. This can include intersex, asexual, or other sexual orientations and gender identities. This list that's on the screen is not by any means exhaustive, but it's a good place to start. So sex, or sex assigned at birth, often refers to the anatomy or the chromosomes that a person was born with. Gender, on the other hand, is a social construct and refers to the socially constructed characteristics of women, men, and the norms, behaviors, and roles associated with each. There are many dimensions of gender. A person's gender is a complex interrelationship between the body, identity, and social gender. So this leads to the description of different types of gender identities. Cisgender refers to a person whose sense of personal identity and gender corresponds with her natal anatomy and birth sex. Transgender refers to persons whose sense of personal identity and gender does not correspond with their birth sex. Remember that gender is not binary, including for those who identify as transgender. Gender non-binary or gender non-conforming or genderqueer are people who reject choosing the binary construct of gender. Genderqueer is a gender identity that is built around the term queer. Now, this last term, transsexual, has been used historically and medically to indicate a difference between one's gender identity and sex assigned at birth. The term is often, although not always, used to communicate that one's experience of gender involves medical changes. The word can have meaning that varies from person to person, culture to culture, and across history. The term transsexual is not an umbrella term, and for some transgender people, the term transsexual is offensive and stigmatizing because of its history and roots in medicine and psychology. So this terminology and distinction is important to be aware of. Sexual orientation, sexual behavior, and sexual identity are all related terms, but they are distinguished. Sexual orientation refers to romantic or sexual attractions towards persons. Sexual identity is how one thinks of oneself in terms of whom one is or is not romantically or sexually attracted to. Sexual orientation and sexual behavior are not the same, and so it's important not to assume based on one or the other. So, how does one approach these terms? Asking openly, "How would you like to be addressed?" can help you find the correct terms. If you misgender someone and are corrected or recognized, you should apologize and correct yourself, and take steps to avoid making the same mistakes in the future. And the issue of pronouns also comes into play. There are many pronouns I've listed on the screen. But again, it's important to mention that there are pronouns that refer to agender, gender non-binary, and other genders, and we can ask how a person would like to be referred to. It is possible that a person does not identify with any pronoun and would rather use their name or this person when talking to or about them. Healthcare providers may not know which or how many of their patients identify as LGBTQ, but all providers will treat LGBTQ+ people in the course of their career. It is critical for providers to remember that any patient could be LGBTQ+, whether or not the person matches stereotypes of LGBTQ people. It's critical that not only healthcare be unaffected by learning a patient's status, but also that rapport remains strong after someone, so to say, comes out. Responds warmly so that they do not fear bias or discomfort. However, healthcare, even in an office setting, usually involves more people and steps than the conversation between the patient and the provider. Care starts as soon as a patient walks through the door, so it's important to educate staff and other personnel about gender identity and using gender-neutral phrasing. Using the right forms that ask both sex and gender orientation questions, as well as preferred name, in addition to name on identification, name for insurance, and other names, and having EHR and other systems set in place to recognize the distinction between these can help patients feel more welcome. Additionally, due to the history of discrimination in healthcare and other settings, it's important to validate patients for engaging in healthcare, especially if they haven't gotten care in a long time. And also having visual welcome signs like rainbow stickers, pins, and flags can help LGBTQ people feel more welcome too. If you have questions on how to make someone feel more comfortable and welcome, you can ask them in a respectful and considerate way. Getting a sexual history is an important aspect of care. However, it needs to be done with caution and sensitivity. Building rapport with the patient is important, so you may not want to get a sexual history on the first visit. Another tip to build rapport is to ask permission before starting to ask about the patient's sexual history. It can be jarring and surprising when you ask first about aspects of social history like diet, exercise, insurance, and then jump right into sex. The CDC recommends the 5 Ps when asking about sexual health. Again, only ask if the patient agrees to proceed. So the 5 Ps are first, partners, and then to understand the risk for STIs, providers need to understand the kind of sex a patient has had recently. One way to ask about this is to ask, what parts do you use or interact with when you have sex? The third P is pregnancy risk, and the last 2 are past history of and protection from STIs. Along with building rapport, it's important not to make any assumptions, including assumptions about a patient's partners. Use gender-neutral and inclusive language as well. There are certain factors that affect medical care for LGBTQ+ patients. These clinical concerns and disparities, of course, can affect anyone, but there is increased mental health, substance use, and HIV risk in certain LGBTQ+ subpopulations, and less cancer screening and vaccine uptake in subgroups as well. Here is a good time to mention that LGBTQ+ population is often grouped together, at least partly due to their shared history of marginalization. But there is significant intergroup variation in these populations. As we talk about these issues, it can be helpful to distinguish how these issues affect different people, so I will be using some SOGI terms. Additionally, I want to mention that while LGBTQ+ people and populations have existed since the start of time, no one was asking these questions, so there's a lack of data pertaining specifically to LGBTQ+ populations and their health. Some clinical trials and studies have extrapolated to LGBTQ+ populations, and so as we go more into detail about these clinical concerns, that's something to keep in mind. The first concern is mental health. The relationship between sexual orientation, gender identity, and mental health is nuanced, and there are many factors that influence psychological stress. Those who identify as lesbian have higher rates of depression, and men who identify as gay have higher rates of anxiety and depression. The increased rate of depression has been attributed to, at least in part, by societal homophobia. Bisexuality was associated with the highest rates of mood disorders. Regardless of where people fall on the spectrum of sexuality, the mental health of LGBTQ+ patients will likely improve in parallel with advances in societal support and acceptance. Transgender people have 4 times the risk of having mental health conditions compared to the general population. There's an elevated risk of LGBT teens, particularly transgender teens, and this elevated risk continues into adulthood. Therefore, it's important to screen for anxiety, depression, interpersonal violence, and other types of violence. And because of the high prevalence of suicidality, ask about prior suicide attempts, especially since we know that that prior attempts prognosticates future ones. We said that finding out that someone identifies as LGBTQ+ should not change the quality of care that they receive, but it should inform the care. There are certain cancer screenings to keep in mind when taking care of LGBTQ+ patients, especially for patients who have natal parts that are different than their outward appearance or identity. The cancers that providers should keep in mind are listed on the screen: cervical, breast, testicular, penile, anal, and prostate. Try to approach screening in a sensitive way. Sometimes, as a society, we use gendered language. So consider asking a patient how they want their natal anatomy referred to. And a screen what you have approach or an organ inventory can be helpful to not forget routine screening. These screenings are important because, as I mentioned earlier, there are disparities in cancer screening and rates of cancer. A cervical pap smear is important to do on those with cervixes, especially for lesbian women who have lower rates of screening and HPV vaccinations. And we know that certain strains of HPV have been known to cause cancer. Additionally, when cytology is sent on a transgender man, the provider must note if a patient is taking testosterone to avoid errors in interpretation. For patients who do not want or are unable to undergo a vaginal exam, a self-swab for HPV is an alternative. Anal pap smears are also a component of cancer screenings for anal cancer. The anal canal is made up of cells that can be infected with HPV and cause anal cancer. Similar to the cervix, you can detect dysplasia in early stages with cytology. Anal cancer rates in the US have been going up about 2% per year, in particular with HIV-infected individuals. And there's a misconception that you have to have receptive anal intercourse to have anal cancer, and that's not true. While there are no national guidelines on who should have an anal pap, several medical societies have guidelines in place that recommend annual screenings for patients who are HIV positive and if the patient has had HPV in the past. Transgender people have been and still are subject to severe discrimination. Discrimination has been well documented in healthcare, education, employment, and interpersonal settings. So it may be very possible that your transgender patient has had a bad experience with healthcare before. Remember that not all transgender patients want to transition medically, and that they may want no medical intervention. So do not assume that someone would want medications or surgery. This means that in addition to a standard health history, providers will want to include history of gender experience, prior hormone use, prior surgical history, sexual history, and the patient's goals related to health and gender transition. Ask open-ended questions to help unravel the gender story. And if it does not come up, consider asking, I'm going to ask you some specific gender questions. Is that okay? You'll want to discuss body image and how to go about cancer screenings and the physical exam. In addition, you'll want to assess for depression, substance use, including a mental health screening, HIV and STI risks, through the sexual history as well. Throughout your care for all people, be mindful of previous trauma and abuse. Again, not all transgender people want hormone therapy or surgery, but some do. Hormone therapy can be initiated in and followed up with in the primary care setting. WPATH, the Endocrine Society, and UCSF Center for Excellence for Transgender Health all have guidelines and protocols available with adaptations for specific underserved populations on hormone therapy. Prescribing and monitoring is now commonly done by the PCP, and previously a major barrier in getting hormone therapy was lack of provider knowledge. Hopefully, the published guidelines by WPATH and other organizations can bridge this barrier. Well-informed patients with realistic expectations have the best results. And psychological well-being must be addressed before starting hormone therapy or changing dosages. Hormone therapy does not generally affect treatment of other health conditions, and there are very few known drug-drug interactions. Maintenance of the possibility of biological parenting is possible, but the loss of fertility can also occur, and so this is something to discuss with patients before initiating hormone therapy. Some patients choose to undergo gender reaffirming surgery. There is a range of transgender surgeries, so language such as pre-op and post-op is inaccurate and potentially harmful. Additionally, there is a psychiatry component involved in this process before a patient can get gender reaffirming surgery. And so appropriate education and preparation for surgery is essential for the best outcomes. The incidence rate of HIV infection has remained steady over the past decade, despite advances in HIV prevention. The number of new HIV infections is about 50,000 annually. Most groups have experienced declines in new infections, but MSM and transgender communities disproportionately account for new HIV infections. Here, MSM refers to the sexual behavior, not necessarily the sexual orientation. In 2010, MSM made up about 10% of the US population, but 78% of new HIV infections among men, and 63% of all new infections. This may in part be due to the different risks of HIV transmission by route of exposure, but it is also due to the lack of testing, barriers to healthcare, and other factors. Condoms can decrease the risk of transmission or infection of HIV by 80%. Adherence to antiretroviral therapy reduces transmission by 96%. There's also post-exposure prophylaxis called PEP, and this is used to prevent HIV when started within 72 hours of HIV exposure. PrEP is the daily use of antiretrovirals by sexually active HIV-negative individuals to reduce the risk of getting HIV. PrEP is an oral pill sold under the brand name Truvada or Descovy here in the United States. PrEP is part of a comprehensive plan, and therefore it's not meant to be offered as a sole intervention for HIV prevention. PrEP is indicated for HIV-negative people with an increased risk of getting HIV, and they must also be able to adhere to the regimen, and that's because efficacy is dependent on adherence. PrEP is contraindicated in those who are HIV positive and those who have poor kidney function. Before initiating PrEP, the provider should do an HIV test, kidney function, check for Hep B and Hep C, and test for STDs and pregnancy in those who can become pregnant. Follow-up testing is recommended to assess HIV-negative status, kidney function, liver function, particularly in those who are Hep B positive. And so you'll want to check LFTs, and you'll want to check for pregnancy in those who can become pregnant, and check for infection with syphilis, chlamydia, and gonorrhea. In addition to routine vaccinations, there are 4 additional vaccines to keep in mind: hepatitis A, hepatitis B, HPV, and meningococcal. For MSM, Hep A, Hep B, and HPV are offered up to the age of 26, and the conjugate meningococcal vaccine is offered to high-risk groups. And high-risk groups include HIV positive, those living in close quarters, and during disease outbreaks. For WSW, there is decreased uptake of HPV vaccines, so talk to your patients about vaccinating for HPV. Contraception and reproductive options are topics that providers tend to skip over in the care of LGBTQ+ patients.
Be sure to ask about pregnancy risks. Don't just assume. Providers should talk to patients and clarify any misunderstandings. There are also some common patient assumptions too. Trans men taking testosterone may not have periods, but this is not contraception. There's an increasing number of lesbian women who are childbearing, often at an older age, which may mean that hypertension and diabetes, which we know increase in prevalence with age, may be issues to look out for during pregnancy. There are many ways to structure families, ranging from insemination from anonymous or donor, to co-parenting with other couples, to co-maternity, and more. And so state laws need to be considered when choosing the method of conception because this can affect parental rights and legal rights. The information provided in this video is really just a drop in the bucket of what's out there. There are many resources online with information regarding LGBTQ+ health. The CDC has a section dedicated to this. Additionally, Fenway Health, which is an organization based in Boston that provides healthcare geared towards LGBTQ+ youth and young adults, has free online modules and LGBTQ health education as well. In terms of finding services, primary care providers and internists can provide care to LGBTQ+ patients, including for transgender care. For those looking for specialized clinics or care, the CDC also has health services located by state and city. Additionally, findhelp.org has a wide range of programs, services, and clinics available that will help LGBTQ+ patients, no matter what they're looking for. Here are the references for the video. This concludes the video on Introduction to LGBTQ+ Health. Thank you. Bye-bye.